All right, so we have some really excellent panelists. First is Dr. Andrew Tatarsky. Dr. Tatarsky has offered psychotherapy and consultation to people who struggle with drugs and their families for over 40 years. He developed integrative harm reduction psychotherapy to address the spectrum of risky and addictive behavior. Andrew is the founder and director of the Center for Optimal Living in New York City, a treatment, education, and professional training center based on IHRP. His writing, teaching, clinical work, and leadership aim to promote a rehumanized view of problematic substance use and a harm reduction continuum of care. Ronda Goldfein is the executive director of the AIDS Law Project of Pennsylvania, a nonprofit public interest law firm that provides free legal services to people living with HIV in Pennsylvania and southern New Jersey. Ronda is the chair of Philadelphia's Police Advisory Commission, the official civilian oversight agency for the city's police department. She's also the co-founder and vice president of Safe House, a public health approach to overdose prevention that seeks to open the nation's first supervised injection site in Philadelphia. Director Lori Criss holds bachelor's and master's degrees in social work from The Ohio State University. Prior to coming to Ohio Moss, she served as the chief executive officer of the Ohio Council of Behavioral Health and Family Services Providers. Director Criss has most recently served on the advisory board to Ohio's Criminal Sentencing Commission, the National Council for Behavioral Health's Addiction Policy Committee, and Ohio's Housing and Homeless Collaborative. She is a former board member for the National Alliance for Recovery Residences and served as the principal advisor for Ohio Recovery Housing. And finally, Suzanne Plymale is a peer support specialist at Community Medical Services, which is the first 24/7 methadone clinic in Columbus. She has lived experience with substance use and experience navigating systems of care. She is an advocate for people who use drugs and an agitator for policy change. And she also performs harm reduction outreach to vulnerable communities in Columbus. All right, and now Dennis will begin the panel.
Hi, everyone. Thank you so much for being here. We're really excited for this event. It's sort of our highlight of the week. We've had Harm Reduction Week all week here on campus, and we've done a lot of great work. We had an event on Monday. We've been giving out test strips and directing people to Narcan on the Oval all week. We're going to continue doing that tomorrow. So if any students want to talk about harm reduction, learn where they can get Narcan, and access some fentanyl test strips, they can come down to the Oval by Thompson Library from 1 to 4 tomorrow. So the way that this is going to work is anyone is free to put things in the chat and be engaged throughout the event, react and that sort of thing. You are not able to unmute yourself just to make sure that the event runs smoothly. And we will start with a sort of moderated question and answer session that I'll direct questions to the panelists. And then there will be an opportunity for Q&A, and I'll let people know when that is. And then at that point, you can put things in the chat or raise your hand and we can unmute you. Okay, great. So we can get started. Our first question has to do with stigma. So stigma surrounding drug use is a huge barrier to progress on reducing overdoses. And the language you use to talk about these issues goes a long way in deepening or reducing that stigma. For example, using language like person who uses drugs instead of stigmatizing language like drug addict. How can community leaders like yourselves help change the stigma of drug use? And this is for anybody who would like to answer.
Okay, I'll start. I think it's, that we keep talking about this stuff, that we talk about it whenever we have an opportunity to. I come from AIDS work, and we always say to people, when you're hanging out with grandma on the holidays, ask grandma what she thinks about people who live with HIV. See what she says about it. Have those conversations. We have to reframe all of that. I think that when Hunter Biden told Amy Robach in that ABC interview, say it nicer to me, when she said to him kind of disdainfully, oh, you have been in and out of rehab. If he had a broken arm that had to be fixed multiple times, nobody would have said that to him that way. And so I think the fact that he pushed back, and sure, Hunter Biden has a whole lot more privilege than all of us, but the fact that he was able to push back and say, no, there's another way to think about that, I think that is where we all need to be.
I just to add, I think there's a lot of discussion right now about anti-racism, anti-transphobia and homophobia and misogyny. I think about drug user stigma in the same way. And let's be very clear, drug user stigma has been driven by racism historically, or sort of an old moral model of drug use. And I think that we need to be willing to, in a way that you were just talking about, Rhonda, to speak up, to call it out. Stigma is so soaked into the fabric of our culture that honestly it lives within all of us. We've grown up, being inculcated with stigma, and it's in the language, it's institutionalized. And so we need to be, first of all, rigorous about looking at how stigma lives within us, even if those of us that have lived experience struggle with drugs, have addiction or recovery histories. But it's a conversation that we need to be continually having and be willing to look at. As a clinician or as a helping person, in whatever role, as a family member, as a counselor, I think the first principle of harm reduction is we have to be willing to look at how we may ourselves be using language or responding to people who struggle with drugs in stigmatizing and harm producing ways. That's the first principle for me of harm reduction helping.
That stigma has really extended beyond just the word addict to, and we don't call someone who has cancer a cancer, right? We call them a person with cancer. And so that person first language is incredibly important to honor the dignity of each person and to recognize that they're a human being first and that they have a condition that's impacting their physical, social, emotional health. But it's not just that word. There's so many other words that, if you think about it within the addiction field, dirty urines. We don't talk about dirty blood screens for a person who's diabetic, right? We talk about a high sugar level, or so using a positive test on a drug screen. Those are the kinds of things that even within the medical professions, we need to be thinking of how we are messaging. Also that whole notion of, well, they haven't hit bottom yet, so they're not ready for help. They'll get help when they want to, is really lacking in respect and dignity for the individual and their capacity to reach their goals. And it creates another level of shame, and that makes it more difficult for people to get help. When we look at some of the national data around why people don't seek support and services, whether it's to be completely abstinent from substances or to reduce their substance use or to get mental health services, stigma is one of the #1 reasons. That sense of shame and the sense of judgment of walking in for help are something that we all have control over and have the opportunity to help reduce that traumatizing experience and create a more welcoming space in our communities, in our neighborhoods, in our medical field as well.
Great. So we're going to move on to the next question. The next questions are addressed to specific people, but after they've concluded talking, any panelist is free to jump in. So this next question is for Director Criss. How have you seen the COVID-19 pandemic affect the overdose crisis, and how long are these effects likely to persist? Have certain places seen the situation improve despite the pandemic, and what contributed to those successes?
So without a doubt, the COVID-19 pandemic added a layer of stress and anxiety to all of us. And internationally, it's been something that's created that additional stress. And we know that it has impacted people who are living with and recovering from substance use disorders in a disparate way. And there are a couple of things there, right? Knowing that having a substance use disorder is something that actually created a higher risk for COVID-19 or more severe consequences from contracting the virus. But also some of the public health measures that were necessary to reduce the spread of the illness were actually even more challenging for people living with or recovering from substance use disorders. So, the social distancing, the need to perhaps not seek services or supports in person. We saw an increase in people using alone and maybe not being near someone who could call for help or administer naloxone if there was an overdose. So all of that combined, we saw increased use of substances and then higher risk of overdose or overdose death because of it. In Ohio, we did see an increase in overdose death, and the mortality data that's preliminary right now is that we just exceeded 4,900 deaths, and that puts it at the highest year on record. And we know that the projections from the CDC will take it to even higher numbers. That's true across the United States. So Ohio wasn't alone in that experience, but I can say that we did some things very early on by recognizing this as sort of a side effect of a natural disaster, a pandemic, that mental health challenges would increase, substance use challenges would increase, there'd be higher risk situations for people. And so we started talking about it very publicly at the press conferences and encouraging people to check in on their loved ones who have substance use disorders, check in on their loved ones who are in recovery, and recognize the high risk nature that the pandemic created. May, June, and July were especially deadly in 2020, not just in Ohio, but again, across the country. I know we'll be talking more about some of the harm reduction strategies in Ohio, but because we had a strong foundation for harm reduction, we were able to deploy more naloxone. And I think that our rate of increase in overdose deaths was lower than other states. I think we ranked 30th if you look at the CDC numbers right now. And I think part of that was because the harm reduction community was activated, the recovery community was activated in using harm reduction messaging and practices. And we implemented telehealth and engaged the treatment community in that too. So. And we engaged families. We didn't just stick to these messages among the professional communities. We really created more messaging on a broader level too. The good news is, I will add this, that it appears that May, June, and July were devastating, but the numbers dropped after that. And so I think in Ohio and in many other states too, that peak hit and then has declined. It has not declined back to where we were pre-pandemic, and fentanyl has a lot to do with that. And I'm sure we'll talk more about that as this hour goes on.
Suzanne, I was hoping you could add more about your own experience.
Yep, I just didn't want to cut somebody off. I can be kind of quick on the unmute. So I just wanted to kind of elaborate on some of my experiences with this through the pandemic. First of all, I think COVID-19 not only disproportionately hurt folks with the diagnosis of substance use disorder, but also people just experimenting for the very first time with drugs. The response times were, a lot longer. And my personal experience working for official organizations, we've been really, really slow to receive Narcan and naloxone from the state pharmacy. And grassroots has really had to shoulder a lot of the weight. And in addition to that, the not-for-profit treatment systems, a lot of them restricted or stopped performing intakes. And the for-profits have really, again, had to kind of shoulder the burden of that, and not all were well equipped to do so, honestly. So I don't know, that's kind of been my experience though.
So our next question is for you, Rhonda. Overdose prevention sites, also known as supervised or safe consumption sites, are places where trained staff are available to monitor people using drugs and are ready to save their lives in the case of an overdose. Portugal, Canada, and Switzerland have all implemented such sites. And there have been no recorded deaths as far as I'm aware of at any of these sites around the world. Safe House in Philadelphia has recently won some court cases that allows it to operate. But what are the biggest factors preventing safe houses opening now? And what is stopping other cities from opening their own overdose prevention sites?
So the biggest factor that's preventing Safe House from opening is that we want to do it legally. And so while we had a big victory in 2020 in the federal district court, 2021 has been a little rough for Safe House. The Court of Appeals ruled against us. And then recently, there was another ruling against us when we asked for a rehearing by the whole panel of the Third Circuit. What that all means is we're on hold and we're still looking at our legal options, but we have kind of moved the conversation forward. And I think that's what's critically important. Like I say, having this conversation tonight, having people continue to talk about this. It's important that Safe House open legally, and we recognize that this is a clinic providing the appropriate care, evidence-based care for people who need it. There's lots of underground sites that are providing that life-saving service, which is great. And I hope that they remain in that business, but it's important that we do that in a legal fashion. So for other cities, actually, nothing's really stopping you. I mean, the order that stops us is directed just to Safe House. So if there were folks in Ohio who wanted to move forward, the order that stops us doesn't stop you. You're still, of course, looking at the federal law, the Controlled Substances Act, which has a provision that says you may not maintain a drug-involved premises for people who use drugs. We've consistently said that our purpose is not to use drugs, but to save lives. We are hopeful, we are always optimistic because you have to be in this work, but we think that we will ultimately get there, and because we have already begun to change the conversation. We've had exciting news the beginning of this month with the Office of National Drug Control Policy issued a quite remarkable statement. And I think Dr. Tatarsky can speak about how that statement came about, but it's quite remarkable in terms of this is the first reveal from the current administration that they want to support harm reduction.
First of all, please call me Andrew, Rhonda. Yeah, this is a historic moment. People should know this, that as Rhonda was saying, this is the first time in history that the federal government has used the term harm reduction. And in fact, until recently, the federal government specifically said, if you want funding, don't use the term harm reduction. So this is history. Not only is the Office of National Drug Control Policy putting harm reduction as one of the pillars of its addiction and overdose prevention platform, but they're also supporting funding. And, in this major funding bill that was just recently passed, $30 million has been allocated specifically for harm reduction services, which is a tiny fraction of what we need, but it's an opening. It's, and once money gets allocated, it's very rare that it ever gets taken back. So it's the beginning. Just very, very briefly, I have been involved with a group of people who have been working over the last year, building a coalition called the National Campaign for Harm Reduction Funding. And we wrote a letter, which is a sign-on letter. I would suggest everyone go to our website, National Campaign for Harm Reduction Funding. Join us. We wrote a letter which has a number of organizations from around the country. We came up with a statement of principles. We were meeting with the Biden transition team, and we think that we had something to do with, that shift. And so we now have an administration that's open to what we're doing, and the more pressure, the more support this administration has from this community, from the community, I think the more that this is going to kind of roll forward. So it's a very exciting time. I also, in terms of activism, I wanted to say that historically, harm reduction has been pushed by activists. It was, people who were using drugs, who were dying of HIV and AIDS, who got together and said, we're going to start giving one another syringes to help stay alive. In Canada, there were a bunch of young folks that set up a supervised injection facility, a pop-up supervised injection facility in parks. They did this in a number of places. And ultimately, the city governments in several cities said, hey, we're going to support this. We're not going to arrest you. And we're actually going to legitimize these. So maybe Columbus or Athens could use a pop-up supervised injection facility.
Just as a follow-up, Rhonda, so you talked a lot about the legal kind of obstacles that you're facing. Are there other sorts of obstacles that you're facing, either like social or within your city, that's kind of making it more difficult?
So when we got the decision from the federal court allowing us to open, we were ready. We had it kind of all mapped out. Like as soon as we had authority, we had to open. We felt like if we could be open for a while, then we wouldn't get a stay, that we couldn't be stopped once we started saving lives. So, we had this great strategy that, I and the other lawyers have been talking about for 2 years. We didn't quite factor in COVID into our plan. But when we announced we were going to open, there was tremendous pushback from the neighborhood in Philadelphia where we were going to open. But then that pushback was kind of loud, but it wasn't the majority of the people down there. And so there was a lot of support as well, saying, no, you have to come here, you have to do this. And so we were like, okay, we have an order, we're allowed to do it, we'll just figure this out, we'll find a new location, we're going to just keep plowing forward. And 2 weeks later, COVID shut down the city. So it obviously became a challenge, but we're still moving forward. Our city council, sometimes city council members, they're, now all designated public health experts, have told us what needs to happen. But I think at a certain point, you just need to move forward in the same way that people didn't want AIDS hospices. They didn't want LGBT health centers. There was a big fight over a Muslim health center in Philadelphia. At a certain point, we don't let mob rule. We say this is an appropriate health initiative and it has to open, and you just kind of keep it rolling.
Awesome. So we'll move on to the next question. This one's for you, Suzanne. What should policymakers do to increase the availability and access of naloxone in the coming years? What have you seen as the current problems with distribution of naloxone?
Okay, so all I can really focus on right now is, what affects us here. And what I know is that there's 24 states that, Ohio is one of the 24 that allows third-party prescribing of naloxone, meaning like a loved one or a person in contact with somebody who's at risk for an overdose. We have the standing order, so that technically under a doctor's signed protocol, a pharmacist can issue the, Narcan or naloxone to a person who's willing to go face the stigma and walk up to a pharmacy counter and, ask for it. And, California in 2015, I guess, removed all criminal and civil penalties and professional penalties for naloxone without a prescription. And that affects folks like peer support counselors, folks that have a credentialing board that, if folks really wanted to, nitpick, like it is a prescription medication that you were slinging on the streets, grassroots, where there's no doctor signed protocol. And the grassroots organization that I'm involved with, Central Ohio Harm Reduction, rough estimate 13,000 Narcan or naloxone doses since COVID hit. So let's see here. Where did I get off track? Yeah, I think that's about it on that. Like there's having cops at your Narcan distros, your health department, you know, organized and furnished, you know, pop-ups are just counterproductive to folks. You know, it really is. And that's the main distro we have here in Central Ohio. You know, and they kind of gatekeep the Narcan also. So, you know, that's why our numbers look like they do. And I'm on a panel with the county coroner's office. And if we keep this trajectory, we're gonna surpass 2020's horrible numbers, which surpassed 2017's carfentanil hit the streets numbers. So it's pretty bad.
So I think, you know, one of the challenging things, Suzanne, that's really helpful perspective, is that different communities are having very different experiences in Ohio. And so as much as there's federal policy that is opening up and federal direction, right? The guidance from ONDCP, SAMHSA's guidance on allowable use of funds, that all helps create that environment for a groundswell of changing practices, because there's not conflicting messages with what the state can do or a local community can do and what the federal government is allowing to. So all of it is very helpful. And Franklin County is definitely experiencing an overdose crisis in an extreme way. And other counties in Ohio are too, but not all counties in Ohio are. And so one of the things we're striving to do is really use data better and to really be more specific around which zip codes are affected too, or which communities are affected, so that we can work to better resource and support local community efforts like the one Suzanne's talking about, so that we don't just have a broad approach, you know, but that we have more meaningful, more equitable approaches, so that these disparate conditions and disparate experiences don't happen across the state. And, you know, we haven't traditionally, I think we're seeing this with the pandemic, right? We haven't traditionally had a strong public health or data infrastructure for public health either. So some of this is more difficult from a resource and planning perspective, and even from an advocacy perspective, to tell that story in real numbers and dollars and cents. And so those are things that we're all working on and we can work collectively towards.
I just want to touch on data real quick. So, you know, the health department Narcan pop-ups, for example, they all require this super triggering, like traumatizing, you know, form. And that's also a barrier. Like when I set up shop literally right next to, say, the syringe exchange, which, you know, their funding comes from here, their Narcan comes from here. Every single participant who wants a Narcan has to answer these triggering questions, right? Like, how did the last Narcan you have, you know, it was used on somebody? Oh, did they survive? Like, that's terrible. We shouldn't have to ask that to give one box of Narcan. And that's the other thing with the like gatekeeping of the Narcan. People are like, can I have 2? It took 5 last time. Nope, sorry, the funding is for this one box. And then they come over here to grassroots and we're like, here, have 10. Please don't take my license, OMOS.
Well, so this goes back to the conversation about stigma. You see, there is so much institutionalized stigma in the policies and the procedures and the language that's used when dealing with people who use drugs, right? Like they need to justify themselves. They need to account for themselves. You know, they can't be trusted. What is all of that about? As opposed to, you know, if not stigma and the presumption that these people, you know, somehow need to be supervised and managed, unlike the rest of us people. And I also need to say, we need to acknowledge as a community that we're all people who use drugs. This, I mean, I just think that that this whole split between those people that use drugs and the rest of us who use our drugs, whatever they are, is really also it's based on this historical kind of otherizing of people that struggle with drugs. And I know that there's a question about this that's coming up, but about this notion of addiction as disease, which is what some people have, and then the rest of us are the normies, or the civilians. When I think there's something really problematic about that framework, because substance use exists on a continuum. We all have substances in our lives. We all struggle at some times with substances. So, I mean, that's a whole other piece of the problem that I think we need to look at and think about.
That was great. So for our next question, this one's for you, Dr. Tatarsky. So what is harm reduction psychotherapy, and what does this process look like for someone who's seeking treatment?
Well, first of all, I think it's useful to think about the original definition of harm reduction by the National Harm Reduction Coalition was harm reduction is a set of ideas and a set of strategies, a set of principles and a set of strategies. And we've been talking about a lot of the strategies, right? Syringe access, overdose prevention, supervised injection facilities. But I think it's useful to kind of back up and think about what are the principles and the ideas as a kind of a framework, right? A framework for guiding how we support people in reducing harm and making positive change in their lives. And for me, those principles are, the central shift away from requiring abstinence or requiring anything, that imposing our values and expectations on the people we're trying to be helpful to. So that enables us then to really honor and respect and meet people exactly where they are, as unique people in unique life circumstances, not imposing our own expectations and judgments on them. And then we can actually create alliances and create partnerships and create, potentially healing and facilitating alliances that support people in discovering what's true for them, what their goals are around their substance use, and what approach to positive change best suits them. So I see that as a frame, like the frame that can frame helping relationships, whether it's psychotherapy, or in Ohio, you folks call it counseling, or peer support, or even family support. If the principles are, we support people on their terms, working collaboratively to empower people to discover what's their truth and what goals and approach to change make sense for them. So if we shift that to counseling and psychotherapy, I've sort of mapped 7 therapeutic tasks. People can read about, stuff on my website. I've got things, but think about creating an alliance as the foundation. We have to be in alliance with people, meaning that we need to join around goals and an approach to change that the individual buys into, meeting them where they are. Now we can create a relationship, and that relationship can facilitate and support healing and positive change. Often people have difficulty with self-regulation or feeling flooded by discomfort, overwhelm, either from the pandemic or from trauma. And so often we need to support people in developing greater capacities to tolerate distress, so that they can actually sit still and now begin to kind of make sense of, what's problematic about my use, what are all the factors that may be contributing to it. And now we can help people begin to set goals on their terms around all of those issues, and create a personalized plan for positive change. So just finally, we might think of it as supporting people in creating their ideal relationship to substances as they define it, which could be safer use, reduced use, moderation, and that would include abstinence for those people for whom abstinence is the healthiest, most self-affirming relationship to substances. That's some of the things that I think about go into that process. Oh, and by the way, I think that harm reduction psychotherapy or harm reduction counseling then can wrap around all of the public health harm reduction interventions, so that, you know, the offer of a syringe can be the point of contact around which people kind of come in. And now we can create a relationship around that, which can then support people in moving from there to their ideal positive change, again, as they define it.
I think that's a really interesting point. I know that, you know, a while ago, I used to think of sort of having a substance use disorder and like seeking treatment for it as just something you do. Like, I've decided I'm going into treatment, and like, oh, before and after. So it was really, you know, enlightening to kind of hear about that sort of as a process and how that fits into the harm reduction framework. So for our next question, we kind of touched on it earlier, and I know that many of you have experience with the treatment landscape, but it's about the disease model of addiction, which is the idea that addiction is spurred by an imbalance in brain chemicals as opposed to a personal choice. I mean, it's widely accepted in many communities now. However, some people have challenged this model and argue that drug use should be rethought. For example, Dr. Carl Hart of Columbia University has advocated for the phrase health and happiness instead of harm reduction. Is the disease model still a good way of thinking about drug use?
I've got a lot of thoughts about this, as I'm sure everyone else does. You know, I think that the disease model is really problematic because it, you know, I think historically, the disease model was an attempt at a step forward, right? Rather than thinking of people that struggle with drugs as bad people or moral degenerates, you know, this was sort of the pre-scientific view. The disease model was suggested as a progressive step. You know, people were not bad, they were sick. And then they could, and this is still the National Institute of Drug Abuse's, I think, big part of the rationale. Folks are sick. They're not responsible for destroying their lives or their families or their communities, and they can get health insurance and get treatment, which is kind of a good thing. All of that is a good thing. But I think that the disease model, it collapses complexity. It reduces it to the drug affecting a vulnerable brain, creating loss of control that the individual now is just sort of a passive victim to. And also it then suggests a whole set of shoulds, right? If you're sick, then what you should do is what we tell you to do. So the doctors tell you, you got to stop. You got to stop seeing all your friends. You gotta. And if you don't, then actually it's your fault for getting worse. Whereas I think of what we call addiction as more of a complex process or syndrome that really starts as an attempt to care for oneself or like a meaningful response to suffering. And that could be related to trauma. It could be related to all sorts of complicated challenges we have in our lives. As we turn to a substance and it actually works and helps, no wonder we want to keep using. The problem is over time, it can become a deeply ingrained habit. It can become kind of networked up in the brain. And now it sort of tends to take on a life of its own. But I think if we think of it instead of disease, but as meaning and habit, then it kind of offers us a whole other hopeful window for supporting positive change. You know, we may be able to find less harmful or more self-affirming responses to suffering. We can also change negative self-defeating habits and develop more effective and healthy ways of coping. So I think that model shift is really a key part of what helps us understand why do people engage in problematic substance use when it also has risks and harms. And that dilemma, I think, is where most people are. And if we can join people there, we can then help them find a healthier way out of that dilemma.
I just want to add to that, that I think that it's interesting how the disease model was introduced so we could feel better about it, right? It was this progressive step, but actually what we have now is kind of feeding to the idea that, if you would only do what you're told to do to treat your disease, then you would be better. And if you don't do that, well, then you're a bad person. And then we get all tied up in that stigma again, different from exploring how it, why people are using the drugs they're using and how we support that relationship. Andrew, you had a great line about supporting people with their relationship with drugs. And it's the whole continuum from doing it safely to abstinence, but it's about respecting each of us and recognizing that we actually know what soothes us and what makes us feel better and what we should stay away from because that doesn't work for us. And I think that the disease model just takes away the freedom from the individual.
It also takes away the complexity of that relationship. It collapses the meaning. I think the fact that so many more people have been drinking and using substances and overdosing during the pandemic is sort of speaks to how, social circumstances which create increased suffering create an increased vulnerability to use substances and in risky and problematic ways. It's not just located as a disease within the individual. I think of it as a response that has something to do with an interaction between the individual, their environment, their relationships, what's happening in the world around us.
Yeah, I think that complexity is at the level you're talking about. And it's also with just using the one label of addiction or of substance use disorder or disease model, because it just oversimplifies substance use and the many different layers and experiences that a person can have with it. And there's substance use that, like you said, is serving a purpose for someone. There's substance use that's unhealthy or dangerous or deadly. And those all need different responses, but they still need a response that the person is engaged in and driving and is person-centered in nature. And that's work that's underway. There is an understanding that it's not just a biological condition. There are dependencies that are created. So physical dependencies, neurological dependencies, those are undeniable. Whether or not that's called disease or not, I think is part of the question here tonight, but it has biological, social, emotional, spiritual aspects to the condition that I think are undeniable as well. And I think that all gets wrapped up into, is it a disease or is it a choice? And I think that perhaps both of those labels have just become poisonous in a way to actually getting to that person-centered care at this point.
Yeah, I think that what you put your finger on, I think that is it a disease or is it a choice? Those are two bad choices. Because I think the experience of addiction is the loss of control or the desperate or use of a substance in a way that one is aware also has potential risks and harms associated with. So that complex experience is something that we need to help people unwrap and take apart so that they can start then addressing all the complex factors you mentioned in more healthy or more self-affirming ways.
So our moderated portion, we'll probably have time for one more, and then we'll turn into the audience Q&A. But this one's for you, Director Criss. Syringe service programs around the country have been successful in reducing the spread of HIV, hepatitis C, preventing overdose deaths, and a variety of other things. However, many programs are limited by certain regulations, including the number of syringes that can be distributed, what other materials can be supplied, et cetera. Also, due to underfunding, many programs are frequently run out of Narcan and other supplies or have to run completely on donations. So how can communities and policymakers best support these programs that we know improve public health?
Yeah, so, I think this harkens back to some of our discussion earlier too, and some clarity from the federal government and creating that more consistent approach, which just really softens the policy landscape for some of the discussions that need to happen and the changes that need to happen. Even the conversation around data, there's different kinds of data. There's, the broader public health data, the coroner reporting versus what Suzanne was talking about, which is, not the kind of data that we want to focus on, right? We don't want to re-traumatize people in their engagement. And so I think we do have an opportunity right now, not just with the federal government, but I'm really grateful that, Recovery Ohio is an initiative that Governor DeWine is committed to, and it put on the map in print straight out of the gate that harm reduction is an important part of a continuum of supports and services that communities need to have. So typically we would have talked about prevention, treatment, and more recently recovery being added into that. And now harm reduction is part of that. We've got a long way to go, but we do have programs throughout the state of Ohio that are a good foundation for us to build on and grow on. I think an example of a more progressive policy, I'll use that term, my colleagues on the panel might not think so, but the nalox boxes, right? That the fact that Ohio passed a law allowing naloxone boxes to be present in communities, and that just went into effect. And we're working to implement how to make those available so that community members have access to naloxone right in the areas where they're most needed, whether there's a pop-up site or a pharmacy or another distribution center open and available to them. So it's incremental change over time. But I will say this, I've been working in the field since 1994, and I can tell you that the day that Ohio opened its first safe syringe program was a day that I didn't know that would ever come in Ohio. And then the day that we started distributing naloxone and having mail order, these are all progressive and incremental changes that are taking hold and making a difference and give us more to build on and to look at. And we have dialogues like this that keep us all thinking and challenged and moving towards what's best for Ohioans.
I think it's interesting you mentioned the nalox box, because I know that me and many of my peers who are at this event, we've tried implementing nalox boxes in various places around Columbus, including here on campus. But it is very difficult. And the university and various organizations around the city are very reluctant. And I think partly it comes from a place of stigma, and it's very difficult. But I just want to share that's something that we've been trying to do here on campus. And if any student who is attending today is interested in getting involved with that work, Buckeyes for Harm Reduction is the place to be. Yeah. We actually have time for one more question that we prepared in advance. This one's for you, Suzanne. Given recent protests about the role of policing, what role should law enforcement be playing in terms of opioid misuse? And how do you feel about Ohio's Good Samaritan law and stuff like that?
Well, I don't feel like we really have a Good Samaritan law, honestly. Maybe I should recap for the folks not living in Ohio or haven't looked into it, but and cops don't have a place, I don't think, because especially here in Columbus, there's a well-documented history of nothing but causing harm, right? Killing sex workers, getting away with it, out on bail now, still in possession of their millions of dollars worth of rental properties around town, like killed while wearing a wire, like killed, it's police don't have a place in harm reduction here in Columbus. But anyway, our Good Sam law doesn't apply to folks on community control, i.e. parole or probation. It only applies to possession, not paraphernalia. It's got to be an F5 or misdemeanor possession that it helps maybe get you out of. And the person, this is one that we don't talk about a lot right here. The person, I was fine tuning my research today to make sure my stuff's still accurate. If a person does utilize the Good Sam and they are questioned by the police and they do have possession, for this Good Sam law to actually kick in, the person does surrender their substances, needs to go take a drug test at a qualified treatment agency and receive their referral, which then has to be turned into the prosecutor. That's our Good Samaritan law in Ohio. So I don't consider it a Good Samaritan law. There was a House bill that died on the floor that would have maybe made it a little more of a Good Sam law. There was one that died in 2017 and one that died last year.
So do they actually want to save lives? Or, you know, I mean, that's the question. I would say that's the question to ask everyone. Do you actually want to be the legislator, the police chief, you know, the university chancellor, whatever, that can say, in this past year, we saved lives, and we can document how many lives we saved? Or do we want to be doctrinaire and, you know, sort of not follow the data? You know, it's sickening, I think.
I forgot another part that's going on in the chat. That's right. You can only use the Good Sam law twice. So even if you fit all of those criteria, you get 2 strikes. So, I mean, what does that really encourage folks to call EMS? And I can tell you that even if you're extraordinarily careful about your wording and saying the person is unresponsive and you don't know if substances were involved, here they will send the police to clear the scene before the EMS is allowed to respond to the person.
That was a great response. I didn't even know about some of the stuff that you were saying about the Good Samaritan law. And I knew some of the stuff, but I didn't realize some of that stuff. Okay, so we're going to transition and spend a little bit of time collecting questions and answers from the audience. I did get a couple in the chat, so I'm going to scroll up, and because I did see a couple that were directed towards me. So someone had asked earlier, Suzanne, what do you recommend to bigger, more organized organizations who want to do better in terms of connecting with their communities?
Go out into the community and ask the community how you can better serve them. Maybe have somebody who's using drugs or in recovery from using drugs, like have a conversation with them. Don't bring police. And don't take pictures of the folks receiving the help. That's usually pretty beneficial.
Yeah, you know, I recently visited in Florida, and I stopped by and visited 2 harm reduction programs. One was a harm reduction therapy program, and one was a peer recovery center. I won't mention the first program's name, but the second program is called Rebel Recovery. And if you want to check out some wonderful folks, check out Rebel Recovery. They've got a full-on peer-driven harm reduction recovery center, which meets people on their own terms, defining recovery as they define it. And I was talking with them and I said, so how did you set up their program? And they said, we went into the community and we said, what do you folks need? How can we be helpful? And their entire program was driven by the community. The other program set themselves up as the experts, knowing what the community needed. And they've been around for a few years, and they can't develop a census. They can't attract anybody to the program because they forgot what you said, Suzanne. You know, ask the folks what they need and work in partnership to support them in creating something that's going to be meaningful to people and relevant. Yes.
So there was another question in the chat. I think this one is for you, Rhonda. So someone said that studies done on existing supervised consumption sites have indicated that they do not affect crime or drug use in the surrounding areas. How do we get that information out in a public information campaign kind of way? They feel like facts fight fear, so how do we get those facts out there?
It's a great question, and there are a couple of facts we should all commit to memory. There's never been a fatal overdose at an overdose prevention site. They've been in operation for 30 years. All the studies show that fatalities in the vicinity decrease. All the studies show that public consumption decrease, drug-related litter decreases, and that there's no impact on crime, which makes sense because it's not a crime-fighting initiative, it's a public health initiative. But there's actually some research that now says surrounding neighborhoods surrounding overdose prevention sites have improved. There's been a benefit to the neighborhood. So all of that research is on the safehousephilly.org website. Please take it, share it, use it, post it on the walls. I think we just have to kind of keep reminding people, this is an evidence-based initiative. We don't have any reason to not save people's lives when we know how to do it.
I guess just like as a larger question, in terms of harm reduction and substance use, there's a lot of misconceptions out there. So I think like, how do we go about making sure that we clarify those misconceptions, that we get people to embrace the harm reduction policies that we know to be effective and that save lives?
And I think that starts where we began this evening, that we keep talking about it, that, you know, I really accept every invitation to talk about this stuff, because I think that the more that we have this conversation, the more that, you know, we're inspired by one another, that's how that word gets out. That's how we become, you know, well-versed. That's how we can talk about that. I think that we normalize this behavior and stop pretending like it's some aberration that we have to lock up or change.
You know, I think we haven't mentioned it, but I think it's worth mentioning that there's often a lot of misunderstanding about harm reduction, that there's harm reduction and then there's abstinence, or there's harm reduction and then there's 12-step recovery, right? Harm reduction and if we really think about the continuum of harm reduction as meeting people where they are in their uniqueness and supporting them in discovering and achieving their ideal positive change goals, harm reduction is an umbrella that actually includes everybody. It's a big tent, you know. It includes 12-step recovery for those people for whom that is their life-affirming choice. And I actually was at a meeting today. Somebody said he's been in long-term 12-step abstinence-based harm reduction recovery. That's his definition. That's the way. But secondly, I think, speaking to this point, everyone here should be or could be an activist, could be a leader on the front lines of pushing this harm reduction movement out into the community, in your classes, in your organizations, with your families. You know, speak up, challenge, you know, what doesn't make sense, you know, engage people in meaningful dialogue. The question is, one other concept, compassionate pragmatism. That's what Alan Marlatt called it. We want to help reduce suffering, but we want to do what works. You know, what we've been doing out there is not working. That's why we have the worst overdose crisis in history. So we need to be evaluating constantly. Is it working in this community with this individual?
Andrea, that your comments remind me of a conversation we had probably 10 years ago around people get really bought into language or their theory or their worldview, right? And that continuum of harm reduction you just described for others is the same thing as the stages of change, right? Pre-contemplative, contemplative. It's all the same intention. It's just different labels attached to it. And people get really attached to certain parts of these continuums. I'm not denying that, but I think the opportunity to seek that common ground, find what we can, work on, build on it, and then continue to seek common ground and not look for those difference or those points of agitation, but for those points of progress, is one way that I think we've made a lot of progress. And I know you and I have appreciated having those conversations over the years, and really, I think they're useful ways to really approach policy changes, practice changes, and that community level change too.
Can I just say, you and I met at a conference that was organized by Integrated Services for Behavioral Health out of Athens, Ohio. And I want to just give a shout out to them, because they are one of the pioneers in integrating harm reduction into a broad continuum of care, mostly doing home-based services for people, just knocking on people's doors and offering to be helpful. And I think they moved into Columbus. And so that's a great organization that brought me and Lori together when we met, and people should know about them. I'm sure there are others in Ohio as well.
We have time for maybe one more question. If anyone from the audience wants to say it out loud, you can raise your hand and I can unmute you, or you can just put it in the chat, whatever's easiest. If you have any questions for the panelists. If not, we can end it there. I think that was actually a good ending point, talking about how we talk to people and get the word out about and challenge misconceptions. So thank you so much to our 4 panelists. I think this was a wonderful event. I also really appreciated how lively the chat was throughout. It doesn't exactly resemble how it would look like in person, but it makes it a little more lively. And I do like that. Hopefully next year for our town hall, we can have it in person. So I want to thank everybody for coming. If you are a student who wants to talk about harm reduction, come by our table tomorrow on the Oval from 1 to 4. We'd be happy to talk with you and give you some fentanyl test strips. So I'm going to also put my email in the chat for everybody. If anyone is interested in joining Buckeyes for Harm Reduction, please send me an email. Or if you just want to keep in touch after this event, that would be wonderful. So thank you to everyone, and have a good night.
It was really great to meet each of you and to see you again, Lori. And I imagine we'll keep crossing paths. Nice to meet you, Suzanne. We've been.
Thanks for giving me a seat at the table, guys.
Rhonda, let's be in touch. I'd love to.
Absolutely.
Learn
And
from
I
you.
think we should all follow Suzanne's model of advocate and agitate. We can't forget that second point. So thank you all.